Welcome to Bloodline Breakthroughs, Innovations and Inspiration. My name is Elissa Baldwin, Director of National Patient Education at Blood Cancer United, formerly the Leukemia and Lymphoma Society, and I will be your host today. We're excited to now offer a video podcast or vodcast and hope you will join us for future episodes where we discuss the latest advances in treatments for blood cancer, as well as hear inspirational stories from blood cancer patients and survivors. On today's episode, we will be speaking to Dr. Gabby Hobbs about chronic myeloid leukemia, or CML. Dr. Hobbs is the clinical director of the Leukemia Service at Massachusetts General Hospital in Boston, Massachusetts, and is an associate professor of medicine at Harvard Medical School. She specializes in the care of CML and myeloproliferative neoplasms, or MPNs, and is an active clinical researcher for these diseases. Welcome, Dr. Hobbs.
Hi, and thank you so much for having me.
Well, thank you. So, our topic today is on chronic myeloid leukemia, or
Yep.
CML. Could you tell our viewers what that is?
Yeah, sure. So, chronic myeloid leukemia, or CML, is a form of, like the name says, chronic leukemia. And it is a pretty unique leukemia, actually, because it is defined or characterized by one very specific genetic change. So, basically, every patient with CML will have an alteration known as the Philadelphia chromosome. And that happens when a piece of one chromosome, number 9, goes and attaches itself to a piece of another chromosome, chromosome 22. And when that happens, it basically puts two genes together that never belonged together, and that's BCR and ABL. And that creates a new protein, the BCR-ABL protein, that basically makes it so that these cells are turned on all the time and don't know how to stop growing. And that leads to the development of chronic myeloid leukemia.
So, what are some common signs and symptoms that a patient might have prior to diagnosis? So, how do patients usually end up being diagnosed?
So it's a full range. Some patients have absolutely no symptoms whatsoever, go to the doctor, they get a routine blood test where they check the levels of their blood cells, and they're found to have elevated white blood cell counts. Sometimes patients can also have really elevated platelet counts, which can be confusing for other diagnoses. But some patients do have a lot of symptoms. So some common symptoms are fevers, night sweats, weight loss, and fatigue. And some patients can have an enlarged spleen and therefore can have some discomfort on the left side of their abdomen where the spleen exists.
Okay. Now, before we get into current treatments, with CML being a chronic cancer, what is the goal of treatment? Is CML curable, or is the goal more of controlling the disease and symptoms for a better quality of life?
Excellent question. Although for sure it's important to control symptoms and improve quality of life, really the goal of CML therapy is to make survival equal to that of patients without CML. And that is an ambitious goal and one that we're often able to achieve in CML. But to answer your question about cure or not, well, that is a difficult question to answer, actually. And so for some patients, they will be on CML directed therapy for most of their life. But some patients are going to be able to discontinue their medications and have what's called a treatment-free remission, a period of time where they are able to be off of their medication. Some patients are able to be off their medicine for just a little bit of time, and some patients are off of it for many, many years. And so some of those patients, one could consider them to be cured. But for those patients that aren't able to stay off medication or are never eligible to discontinue their medication, the goal really is to live a normal life and have a normal life expectancy while also minimizing the side effects of the medications that are used to treat CML, so that even if patients may need to be on a medication, their quality of life can be maintained.
Okay. So how is it that they are able to go off medication? Are you just determining that the disease seems very well controlled, in deep remission?
So, in a disease like CML, where life expectancy is normal to age matched controls, it
Mhm.
is very important to follow very strict guidelines. And so now there are standard guidelines and recommendations by organizations both in the United States and Europe. In the United States, it's called NCCN, and in Europe, they're called the ELN guidelines. And these are guidelines that every doctor has access to.
Hmm.
And they basically say they're slightly different in the United States and in Europe, but they basically say if you've been on your medication in the United States, we say for at least 3 years. And for the last 2 years, you've had a deep remission, which is defined in our terms as an MR4, meaning a level of that BCR-ABL protein we were talking about of less than zero point zero 0.01, then you are eligible for discontinuation of your medication. An
Okay.
important caveat to that, however, is that you don't just stop your medication and then tell your doctor, see you later, I'll come back at some point, because that would be dangerous. So, an important part of stopping the medication is that you're then able to check your levels very frequently to make
Okay.
sure that if it does come back, then you promptly get started back on medication, because we certainly don't want to take a patient that was in an excellent remission and then not monitor those patients closely and have them come back, with uncontrolled disease.
So let's talk about treatments. What are the current treatments for CML?
That's a great question. So we are very fortunate in chronic myeloid leukemia to have really an excellent selection of medications for our patients. And I always like to talk about this when talking about CML, but really in 2001, the first medication to treat CML was approved, and that was imatinib. And I have to say that that medication really marked a watershed moment in the fields of oncology in general, and of course for CML specifically. And so it's important to take a moment to remember how momentous that occasion was. Whereas before 2001, the most common indication for bone marrow transplant was CML. And
Hmm.
now, after 2001, one of the least common indications for bone marrow transplant is CML, just to kind of highlight how wonderful these medications are. So anyway, in 2001, we had the first medication approved, and that's called imatinib, also known as Gleevec. And since then, we've had other medications approved. So imatinib is considered a first generation TKI. All of these medications are what are called tyrosine kinase inhibitors, or TKIs, because they block that kinase, which exists in the BCR-ABL, an enzyme. So imatinib is a first generation drug, and then we have a few other drugs. So we have dasatinib, nilotinib, and bosutinib as our second generation drugs. And then very recently, we had the approval of another drug called asciminib. And so now we have all of those drugs available, those 5 drugs available for use in first line. I mean, a patient just gets diagnosed, and we have to discuss which medication to start their treatment with.
Hmm. And are there any other medications available? We've heard a lot about CAR T cell therapy and immunotherapies like bispecifics. They've been getting quite a little bit more attention over the years.
Yeah.
Are CML patients eligible for those?
Yes and no. So to answer one question, because you asked if there were other treatments available. So
Yes.
one treatment that is available that I did not mention is ponatinib. Ponatinib is an excellent medication also for our patients with CML, but it's just not approved in first line. In
Okay.
terms of immunotherapies and CAR T cells, really for our chronic myeloid leukemia patients, and I'll explain what I mean by that in a second, those therapies are not available for them.
Okay.
And the reason for that is that they do very well with the medicines that I listed now. So you really can't improve upon, normal survival.
Hmm.
Now, for patients that don't have disease that's well controlled with these medicines, CML is a disease that can progress, especially without treatment. And so sometimes we diagnose patients, and then occasionally patients will have progression on treatment from this chronic phase of chronic myeloid leukemia to what's
Hmm.
called blast phase. And there used to be a terminology used also called accelerated phase, which is basically a phase in transition where it's going from chronic phase to this blast phase. Blast phase is a disease that looks more similar to acute leukemias, and that could be either similar to acute myeloid leukemia or acute lymphocytic lymphoma, and or lymphoblastic lymphoma, sorry. And for ALL patients, we do have CAR T cells available and
Hmm.
immunotherapies that are available, but that is really a tiny percentage of patients with CLL that may end up being eligible for that. So generally speaking, I would say the vast majority of CML patients are going to be treated with the medicines I mentioned, those TKIs that are pills, and not generally with those other medications.
Okay. So you mentioned a lot of first line medications and then a second line. So what happens then if they relapse again? Are there any other treatments available?
So now that we have 5 drugs for first line use and then ponatinib,
Mm.
we really rarely have to move outside of that class of
Okay,
drugs.
good.
So, a patient may start on imatinib and perhaps not do well, and then perhaps move to a second generation drug. And then they have the option of asciminib or ponatinib. And so it's rare to have a patient that has had true resistance to all those kind of like first generation, second generation, and third generation. Now, for the patients that really do not have disease that is well controlled with any of the medications that we have, um, then we do occasionally consider a bone marrow transplant for those patients. But I would say that that happens very, very rarely, like in
Okay.
much less than 1% of the cases.
Well, that is very good to know. Now,
Absolutely.
what about side effects of these medications, particularly of the TKIs? Could you
Yeah.
talk about those and if they're manageable?
So that is a great question. And I think that now that we have so many treatments available, we really have to think about our treatment, not just in terms of getting patients in remission and getting them to live longer, but also to ensure that the time that they live with their CML also has really good quality of life. Because, we now have more drugs available. So we
Yes.
have more medications to offer our patients. And so, yeah, there's definitely side effects to these medications. And so for the prescribing clinicians, it's very important to know what those side effects are in order to be able to offer our patients excellent supportive care. Um, and one important thing to know for patients is that the most difficult period of time, for many reasons, is the first 3 months of diagnosis. First, there's the emotional component of having a new
Mm.
diagnosis, but second, these medicines really tend to have more side effects at the beginning, and then as the leukemia burden has gone away, because these medications get rid of those leukemia cells, the side effects actually get better. And so, an important part of being able to successfully remain on treatment is to kind of recognize that those first couple of months may be the hardest, but it's going to get better.
Okay.
That being said, there are some side effects that can continue, after those first couple of months. And so there's definitely many side effects that these medications can have. And so, in addition to supportive care, once patients get into a good remission, one of my favorite strategies is actually to lower the dose of their medication, because certainly it's the medication that's causing those side effects. So if you can take
Yeah.
less medication, that oftentimes really helps um, patients have less side effects. And then if we've tried supportive care, if we've tried lower doses and still things aren't working, well, thankfully, we're now in an era where we don't just have one medication, we have several medications. And so it's not unreasonable to switch from one medication to another because of bad side effects. There may be some side effects that are shared across the classes of drugs. Fatigue may be a common one. There's many
Mhm.
of these medications that have GI side effects, like nausea or diarrhea. But just because you've had one side effect with one medicine doesn't mean that you're going to have those same side effects to other medicines.
Okay. So let's talk about the future of CML treatments. What treatments are in clinical trials or on the horizon? Is there anything that you're really excited about?
Well, I think honestly we should probably take a second to talk about a new medication that was just approved
Yes.
as really a fruit of clinical trials, because there's been many for this medication and it's created a lot of excitement in the field, and I'm sure that our listeners are probably going to be thinking about that one. So
Okay.
asciminib is the most recent drug to be approved for the
Hmm.
treatment of CML, and it really has addressed a lot of important questions in the care of our patients because it is such a well tolerated medication. And so, this medication was initially approved for patients that had not done well with two TKIs or two
Okay.
medications. So, it was approved in third line. And then recently, at the end of last year, it was approved for first line. So that's really
Mm.
changed a lot of how we think about things, because
Yeah.
it's a well tolerated medicine. It's a very powerful medicine. And so we're all left with the question of, should we just use this medicine for everybody? And I don't have an answer to that yet.
Okay.
We know that, when you compare all of these medications together, none of them has been demonstrated to lead to an improvement in overall survival, because again, survival is normal in CML. And so we measure success then differently. And so one important way is, how deeply do you get into remission? How quickly do you get into remission? How many patients are able to discontinue their medication, and how well tolerated it is? And so those are all the things that we consider when selecting treatments for our patients. But asciminib is really a medicine that I think is probably in the minds of a lot of patients that have been diagnosed with CML either recently, or even those patients that have been diagnosed for some time. And so that one has been recently approved. In addition to asciminib, there are other drugs that are being studied for sure, and some of them are kind of similar to asciminib in the way that they work, but trying to kind of build upon that medication to make it even more well tolerated or even more potent. And there's definitely other medications that are similar to the other medicines that again try to overcome some of the issues that the other ones have, and trying to improve side effects and efficacy. So it's possible that in the next couple of years we'll have some newer medications to add to these already excellent medications. There's been efforts to try to combine the TKIs together, so the medications together. An example of that is asciminib, because it blocks that protein, that BCR-ABL, slightly differently than the others. There's been efforts in some of those studies to combine and say, let's give asciminib in combination with imatinib or in combination with dasatinib. So that could potentially be a strategy. It's not approved yet,
Yeah.
but it's something that we think about for patients that have disease that's very resistant to therapy, for example, and something that we have also started investigating in patients with ALL, which is a disease that shares that Philadelphia chromosome in some cases. And
Mm-hmm.
so that strategy of two drugs together to see if it's better, something that's under investigation. There's also been, combinations with medications like interferon that
Oh,
hasn't really yielded too many
okay.
great results. It's not that easy to tolerate both of those medications.
Mm-hmm.
So yeah, lots of research available, but really we are very blessed in CML that we have these excellent medications, and we're excited to have a new medicine to add to our armamentarium of medications.
Yes, absolutely. It definitely seems that combinations are starting to get more popular in the blood cancer space in general, just combining these drugs and trying to
Right.
figure out what works best.
I think, and what's so interesting is that in CML, when asciminib wasn't approved, the initial studies were trying to combine. And then they kind of realized, actually, this medicine is so potent by itself that we don't need to combine it with something
Great.
else. So CML is unique compared to the other blood cancers, where
Hmm.
because there's only one genetic mutation, and these medicines block that mutation so well, we really haven't needed to resort to combinations. But certainly for some patients with resistant disease, that is an interesting consideration.
Yeah, absolutely. So, our final question today, Dr. Hobbs, this program is titled Bloodline Breakthroughs, Innovations and Inspiration. So, how would you envision the current or future treatments we talked about today changing patient outcomes?
So they really already have. And I think that the next frontier, I think, for CML management, there's two things. One is being able to help patients to remain off of their medication for longer, and I'll talk about that
Yes.
in a second. But the first, and really the part that impacts every single patient with CML, is to make sure that patients not only have well-controlled disease, but also have medications that they can actually tolerate. So, one thing is asking a patient to take a medication for a week and being like, well, you're going to have XYZ side effect. All right, well, you kind of tolerate that for a week. But it's very different when you ask a patient to take a medication for years before they're eligible for discontinuation and expect that that patient is going to tolerate, significant side effects for that long.
Mhm.
And, as an investigator, I read journals and magazines and publications about these medications. And oftentimes, a common term that is used is, well, this medication was well tolerated. And it's easy to say that as an investigator, but as patients that are taking medicines that have these low grade toxicities like fatigue or having, several loose bowel movements a day or low grade nausea or et cetera, it's actually a big deal in terms of your quality of life, especially for
Yeah.
patients that work or that are busy, or any patient really. And
Mhm.
so I think what I would like to see in the next couple of years is recognition that that quality of life piece is just as important as meeting our milestones and trying to get people into good responses. And so, as I mentioned kind of earlier in our conversation, recognizing that if a patient is in remission, that we can actually safely lower the dose of their medications
Mhm.
with close follow-up to ensure that efficacy continues is such an important part of really fully taking care of our CML patients to ensure that not only are they in a great remission, but that their quality of life is also great. And to go to what I said when you first asked this question, one of the frustrations as physicians that care for patients with CML is that we have patients that meet all the criteria for discontinuation of their medication.
Mhm.
And then a month or two later, their disease has returned and we need to put them back on medication. So I
Oh.
wish that I had a strategy to say, either I'm going to use two drugs at the beginning, or I'm going to use higher doses, or I'm going to use an innovative drug or something like that to really make sure that I get you into this deep remission. And then I'm able to keep you in remission so that once I stop the medicine, we're able to really stay off the medicine and not just go off the medicine for a month or two and then go back. So that's really, I think, a frustration in our clinical care of patients that we stop the medicine and then we have no control over who is going to remain treatment free for many years and who is going to relapse right away.
Right. Yeah, that would be very tough.
Mm-hmm.
But it's just amazing how CML treatment has advanced over the years, and with the incredible change when Gleevec came on the market. And we've talked to many patients, including one of the first ones that was on one of those trials. And he's still living today and
It's
doing great.
amazing.
And I
Yeah.
just saw him a couple weeks ago, and it's just incredible. And he was given 3 years to live. And so it's amazing how far we've come with CML
Absolutely.
treatment. And I'm excited to see the future and what we might be able to do with combination treatments, or how asciminib works out
Absolutely.
and keeps working for patients. And so thank you so much, Dr. Hobbs, for joining us today and telling us all about CML. And I'm sure you've given a lot of hope to particularly newly diagnosed patients who are watching right now. And so really appreciate you joining us today.
Oh, it's my pleasure. Thank you so much.
And thank you to everyone tuning in to our latest episode of Bloodline Breakthroughs, Innovations and Inspiration. Visit the link below for more information about our topic today, and we look forward to seeing you next time.